had technical difficulties this morning with the live webinar. My name is Anand Kalra. I work at Transgender Law Center as the Health Programs Manager, and I'll be running through today what is happening right now with Medicare, and I'll give a little bit of lead up into how we got where we are, and then talk about specific tips for submitting comments of your own, or if you'd like to join the comments that we have been coordinating as a working group, that information will also be provided at the end. I want to acknowledge that this morning, in our first attempt, we had folks from National Center for Transgender Equality, National Center for Lesbian Rights, American Civil Liberties Union, and Justice and Aging as well, scheduled to be available to answer questions and comment on these topics as well, but unfortunately we are just winging it to make sure that everyone is able to access the information in a timely manner, since it is such a short turnaround, especially with the holidays. So without further ado, I will dig right in. We actually don't need this slide anymore. So as I said, I'm going to talk about how we got to where we are, what this moment really is, and give some advice on comments. So what has been kind of in the background setting the stage for the current moment is that in 1989, Medicare adopted a national coverage determination, which is a national policy with the number 140.3 that excluded coverage for gender reassignment surgeries categorically. And it was based on clinical evidence collected in 1981. So even by 1989, the information was really already outdated. The national coverage determination said things such as that gender reassignment surgeries were experimental and unproven to be successful in treating gender identity disorder, what we now call gender dysphoria. So that had been the case. So any Medicare beneficiary was unable to access gender reassignment surgeries under Medicare with Medicare as the payer since 1989. Then in 2013, NCLR, the ACLU, and GLAAD filed a challenge to that national coverage determination on behalf of an individual beneficiary named Danae Mallon. This was done going through the channels within the Department of Health and Human Services federally. May 30th of 2014, the Health and Human Services Departmental Appeals Board invalidated the NCD based on that challenge that was brought by NCLR, ACLU, and GLAAD. And they ruled that the categorical exclusion for gender reassignment surgery was not valid under the reasonableness standard in the Medicare policy manual. So what it meant was that, one, the blanket exclusion was removed, and that Medicare administrative contractors, which I'll explain what those are in just a bit, are not allowed to use that national coverage determination that had the blanket exclusion in making their own determinations of local coverage, local coverage determinations, which are things that they would administer in their own geographic jurisdictions. In absence of a guiding policy, either a local coverage determination or a national coverage determination, requests for gender reassignment surgery were supposed to be reviewed case by case. So since that May 30th, 2014 ruling, we've seen some barriers with implementation. I'm sure everyone who's listening to this is already aware of several of these, but I'll just run through them. So one thing is that pre-authorizations are not allowed in Medicare fee-for-service plans. So when we think about the private side or even in Medicaid context, how to get people through these insurance channels, we typically recommend that the providers submit a pre-authorization or request for prior authorization or pre-approval. You know, there's several terms that may be used before any treatment has been provided, so that in case there are barriers and denials that come up, people are able to appeal those and get through this before any cost has been incurred. But by statute, unfortunately, with Medicare fee-for-service plans, which are the Part A and B plans, they just cannot do those pre-authorizations. So what it means is that in practice, only people who are able to front the money for surgery have been able to kind of go through, who've been able to go through that process have been able to access surgeries if they can find a provider who bills Medicare, which brings up the next issue. So network adequacy or the provider shortage overall. As far as I know, there are 2 surgeons that I have confirmation of in the entire country who are able to bill Medicare for gender reassignment surgery and have experience doing gender reassignment surgery, so they're not kind of, you know, new at it. You know, of course, that creates a really big problem of a bottleneck. One reason that there are so few surgeons is that the reimbursement rates through Medicare for these procedures are very low. So, for example, it comes down to something like $1,100 for a vaginoplasty, which is very, very, very far below market and below cost. So if it's a surgeon in a private practice who wanted to enroll in Medicare in order to provide these surgeries for Medicare beneficiaries, they would really not be able to balance the numbers in their practices to be financially solvent. Because if you're a Medicare provider, you're not supposed to bracket out, we'll take this percentage of our clients from Medicare and this percentage from that. If you are a Medicare provider, you're supposed to take all Medicare beneficiaries who come to you. So it just is not financially feasible. Another barrier is that none of the Medicare administrative contractors, and again I'll talk about those in a second, implemented local coverage determinations. So what a local coverage determination would do is list out kind of what are the eligibility requirements, what are the documentation, what are the covered procedures, what are the hoops people have to jump through in order to access surgeries, and then what kind of surgeries would be covered. So in absence of that, there's not clarity around what is and isn't covered and what people have to do, both from the provider perspective as primary care people referring folks for surgery, as well as for patients trying to figure out, what is this complex system that I'm trying to navigate, as well as, on the contractor side. One Medicare administrative contractor did propose a local coverage determination. It was very restrictive and was open for public comment. So Transgender Law Center, ACLU, NCTE, NCLR, GLAD, I'm going to miss some groups here, but a bunch of us worked together last November, so November of 2014, to issue a public comment on that and explain exactly why each restrictive part was restrictive and why it was not in line with evidence-based medicine and not in line with really trying to provide access to care. So that is where we kind of started off as being an organized group, was around that public comment, and then we have continued since then to work to try and identify strategies to reduce these barriers to implementation and barriers to access to care, as well as figure out one, the strategy, and then two, actually following through on that. So thinking about that, we were applying a model that was used successfully by the neuropsychology associations, in that what they did is, instead of waiting for the local contractors to issue their policies and then do public comments on it, they tried to be more proactive. So they wrote a model policy with clinical evidence supporting it, and submitted that to the carrier advisory committees, or carrier advisory committee with one of the contractors in particular. I believe it was Wisconsin Physician Services, which covers a few states in the Midwest. And that was a successful strategy for them, and that their policy was then influential in determining the policy that contractor eventually did adopt. So we decided that was going to be what we were going to do, and try to get a good policy in place at the local level with at least one contractor, and then work up from there and try and kind of map it out across the country. So when I'm talking about Medicare administrative contractors, who I'm talking about are these private companies that CMS, the Center for Medicare and Medicaid Services, contract with to administer Medicare benefits. So they're not insurance companies in their own right, but they just are administering these benefits. They're contracted to kind of handle all the paperwork and do all the claims administration. There are, gosh, I'm forgetting now if it's 8 or 14 of these companies, I think it's 8, in 13 or 14 jurisdictions throughout the country. These jurisdictions change pretty rapidly. So you see on this map here, they're color-coded to say what the names of the jurisdictions are. So JE, JF, J5, J6, and things like that are the names of the jurisdictions. And then you'll see the company's name in the little bubble under it. So for example, Noridian is the Medicare administrative contractor for jurisdictions JE and JF, which cover a vast part of the country, geographically as well as by population. So these are the companies that would issue local coverage policies, and when we're saying local, it would apply to their entire jurisdiction. So the proposed local coverage determination that we commented on last year and that eventually got put on hold was from Novitas Solutions, and they have JH, which is down here in the south, a bit of the southwest, bit of the southeast here, as well as up here in Pennsylvania, New Jersey, Maryland, Delaware. And I forget off the top of my head if DC is in that or not, or if they have a separate one. So that's kind of the landscape that we're looking at. So what's the difference, what's the advantage and disadvantage of having a local coverage determination versus a national coverage determination? This chart, I'll let you take some time to look at it on your own, but basically the major differences are that local coverage determinations, of course, apply to the geographic scope of the Medicare Administrative Contractor jurisdictions, for the MAC that is writing that. So Noridian would write a policy that covers Noridian's jurisdictions. Whereas a national coverage determination is, of course, national. The difference, really comes down to then you could have local coverage determinations in different jurisdictions that say different things. They could contradict each other. They could cover different types of surgeries. They could have different eligibility requirements, and that would be okay based on what the law and policy is. It's okay for those local coverage determinations to not be completely standardized. Whereas a national one, of course, is standard for folks across the board. They both would apply to fee-for-service as well as Medicare Advantage, that's those Medicare Part C plans, but differing by the jurisdiction. If it's a local one, or at the national level would be all over the country. With local coverage determinations, there can be exceptions made on a case-by-case basis. If, for example, let's say that hormone therapy was listed as being required as a prerequisite to surgery, and then it was contraindicated for a particular patient, they could make an exception for something like that. Whereas with a national coverage determination, what is written in the policy is really set in stone, and there can't be exceptions made to that. This also comes up in the context of appeals. If a procedure is denied based on a local coverage determination, an administrative law judge can go above that basically and look at Medicare law on its own to see if the request could be granted under the law itself, regardless of what the local coverage determination says. Whereas if there is a national coverage determination, the administrative law judge in an appeal can't do anything above and beyond that. And then finally, the authority of kind of who's kind of up the chain is the Medicare Administrative Contractor's medical director for a local coverage determination, and then the Health and Human Services Secretary all the way at the top for a national coverage determination. So looking at this chart, our strategy had been to try and do local coverage determinations because they're more flexible, and thinking particularly about procedures for which there isn't as much clinical evidence currently in the literature, or at least at the time we were thinking about this a year ago, particularly things that keep being classified as quote-unquote cosmetic, which of course end up being things that particularly affect trans women, like facial reconstruction surgery, facial and body hair removal through laser hair removal or electrolysis, tracheal shaves, and breast reconstruction. So of course these things are not cosmetic. They are very often necessary for a particular person's transition, and it's just not as strongly reflected in the literature as things like genital surgeries because there's so much emphasis in medical literature on genital surgeries. So the idea was to be able to take advantage of the flexibility so that we could build up some case law before going through with the national coverage determination. But that was not to be. So this year, 2015, several things happened independently. One is that our working group met with the CMS Coverage and Analysis Group, well, actually in December of 2014 and then again in September of this year, to talk about some concerns that we had around implementation, which are the things that I've already discussed, and I'm sure things that you have experienced either as providers or as advocates. They were very open to hearing our feedback and our input, and advised us that they had received a request from an individual Medicare beneficiary for a new national coverage determination. So recall that the previous state of affairs was that there was this blanket ban on coverage for gender reassignment surgeries. This was through a national coverage determination. When that one got invalidated, there was not a replacement of an affirmative policy. So an individual Medicare beneficiary this year in 2015 requested that. Now there's a formal process for that that triggers certain things. CMS opted to respond to that request and has issued the national coverage analysis tracking sheet. And I think I have that on the next slide, so I will pause on that. So meanwhile, kind of, back home on the range, on a totally separate issue, the Department of Health and Human Services issued proposed regulations on the Affordable Care Act, Section 1557, which I'm sure most of you are already painfully familiar with through having heard advocates talk about it for the last 5 or 6 years. So of course, this is the non-discrimination section of the Affordable Care Act, and it applies to a great number of healthcare contexts. Any healthcare setting that receives federal funding is prohibited from discriminating based on a number of protected categories, including gender identity and gender expression. As the regulations were proposed, this applies to the level of benefits administration in all of these federal programs, for example, including Medicare. So now there are kind of two things backing the idea that there needs to be clarity around what coverage looks like under Medicare. One being that Departmental Appeals Board ruling that overturned the old NCD, and the other being Section 1557. So that brings us up to speed where we are now. I'm going to take a breath for a second. Okay, so December 3rd, last Thursday, CMS, the Center for Medicare and Medicaid Services, Coverage and Analysis Group, which is the group responsible for researching and writing coverage policies, released the National Coverage Analysis Tracking Sheet. So what this is an announcement saying that they are going to determine whether or not to produce a new national coverage determination. And if they do, this process right now that we're in will determine the scope of that. So they listed on the tracking sheet that they're particularly interested in scientific evidence that, in comments that include scientific evidence, so clinical research, and comments that address the breadth of the request, so the scope of surgeries, which kinds, what variations, and that kind of thing. Overall, the goal of this process is to determine whether health outcomes are improved for gender dysphoria based on gender reassignment surgery, which we know, kind of in broad sweeps, that they are, of course. So, from an advocacy perspective as well as from a clinical perspective, I think we're in a really good position now because the evidence is there, it's plentiful. We've gathered much of it already together, and really the evidence is on our side that treatment works, right? It has all these positive outcomes. So we're in a good position for this. The timeline now is that comments are due on January 2nd, which happens to be a Saturday, so just keep that in mind. January 2nd, which is coming up very, very rapidly. Then CMS has 6 months from the date that they issued the announcement to compile all their research and then issue a proposed decision. So when they issue the proposed decision, they're going to say whether or not an NCD, national coverage determination, is justified based on the evidence. And if they decide that it is justified, they will also release a draft of the policy itself on or by that date. So then that will trigger another 30-day comment period on the proposed decision itself. So that is a period where we are envisioning would be particularly useful to have many, many, many people commenting, both individuals and providers, depending on how this thing comes out. If it's very strong, of course, we'll express our support for it. If it's weak, we'll express our dismay at it and argue that it should be more comprehensive. If it's somewhere in the middle, we'll say thank you for the good parts and hey, we hate that for the bad parts, and of course, suggest solutions. So that is where input will be kind of more typical to what we're used to seeing in the form of a public policy comment. The place where we are right now for the comments really are focused very, very heavily, if not exclusively, on that clinical evidence piece. There's no harm in people submitting their own testimony or their own experience about barriers accessing care through Medicare, but we're not sure how much punch that'll pack at this point, but there's no harm in it. So again, that second comment period where it would be, we think, very useful to have lots and lots of people commenting, will begin June, or it begins the day that they release the proposed decision, so it has to be by June 3rd, and then would conclude 30 days later. Then 60 days after that, the final national coverage determination becomes effective. So they issue the proposed decision, then there's 30 days of comment, then they have 60 days to revise it and republish it, and then it becomes final. So we're looking really at another 9 months or so in terms of when something would really be effective. It's possible that it could happen sooner, but to the best of my knowledge, I would anticipate that the kind of upper limits, so the full 30 days, the full 6 months, the full 30 days again, then the full 60 days is what we're looking at. So comments themselves, what are we thinking about? There's several options. So as a working group among us advocates, as well as we have some wonderful providers on board who have been working with us since November of 2014, we have developed a model national coverage determination. So we looked at other coverage determinations to get a sense of the form and the flow and the categories and kind of how things are structured. We matched that. We looked at other examples of coverage policies from the private side as well as from other public insurance like Medicaid, and also made sure that we defined the basics ahead of time, because we want to keep in mind that though those of us in the advocacy and clinical world who work on trans issues a lot are very familiar with the ins and outs, we wanted to make sure that we were thinking with the audience in mind, who are folks who are probably very well intentioned but are new to the issue and really need to be grounded in what is gender dysphoria, who are transgender people, how many of us are there, you know, is this a real thing, all that kind of stuff. So there's some introductory stuff. There's a bit of mention about Medicare's own stance, what it says in the policy manual about the issue of cosmetic versus medically necessary care or reasonable care, and put together what I think is a very strong draft. It's been revised, I think, 5 or 6 times at this point, and there are still a few things that will be added to it over the next few days, including some enhancement of the sections on facial reconstruction surgery, and some folks are adding in some additional CPT codes. But overall, I think, you know, definitely the bulk of it is there. If you click on this link here, you'll be able to take a look at it. And if you have any particular comments or see things that are missing, please do feel free to email me directly about that. We also then separately put together a summary of clinical evidence in support of various procedures. And we really go kind of procedure by procedure using the categories that are outlined in the WPATH standards of care. So surgeries, genital surgeries, and other surgeries. There are, I think we packed in, 82 citations into something like a 4 or 5 page document, so it's very well cited. And again, if you want to take a look at that, and if you have additions to add, we're happy to have that input. If you decide you like what you see, you can click on this link here to enter your info and be a signer or an endorser of the model NCD, which we will submit as a comment. We did circulate an earlier draft of this document with the coverage and analysis group, and they indicated that it was in line with the kind of thing that would be helpful. So we have that feedback to know that we're on the right track in terms of providing things that are really going to be helpful for them as they go through the evidence to think about writing this policy. Another option, of course, is you can submit your own comment. This link here will take you to the National Coverage Analysis Tracking Sheet, where you will, check a box to say you acknowledge the PHI, forgetting the H right now, that you acknowledge the policy around private health information. And then you'll enter, your basic information, name and organization and address and things like that. And then there's just a comment box where you can type in what you are commenting on. So whether you support or oppose Medicare issuing such a policy, I think it would be particularly helpful to focus on outcomes. If you are a clinician, it's always great to mention what kind of clinician you are. If you're a primary care or endocrinologist or surgeon, if you're a doctor or nurse practitioner or nurse or physician's assistant or medical assistant, mental health provider, it's always great to be specific with that. It's great to mention outcomes that you've seen. So, I'm a primary care physician who's been working with transgender patients for the last 15 years, and I've treated more than 30 million, 15,000, 1,500, however many folks you think you've worked with over the years that you've been working with them, and establishing that you've seen people's overall health improve, quality of life improve, mental health improve, physical health improve when they're able to access transition-related care and when they're able to access particular surgeries. It's particularly helpful, if you recall, when on an earlier slide I had talked about that the tracking sheet asks specifically for comments on that include scientific evidence as well as comments on the breadth or the scope of surgery. So I think when we're looking at that, we're particularly looking at the issues of things that keep getting called quote unquote cosmetic, though we know they are not cosmetic. So things like facial reconstruction, body hair removal, breast reconstruction for trans women. If you have specific information that you want to add about benefits that you've seen with clients or patients of yours who are able to access those things or the necessity of them, the kinds of changes that result in their life as a result of having access, those are very helpful things for the CMF folks to be aware of. If you'd like to include a statement saying that you support the model NCD working group's model NCD, we would be happy to have you say that, but it is your comment and you can say what you wish in it. So this is the point during the webinar in which we would allow people to ask questions, but unfortunately because we are working with what we've got today, there's no one on the line except me right now. So if you do have questions, please feel free to email me. My email address is right there on that transgenderlawcenter.org. And if it's something that makes more sense to go to another person, I will get you to the right person about that. I'm happy to provide any other information that would be helpful. And these slides will be in the email that I send out. I think by the time you are watching this, you will already have the slides in front of you. These links will be active. And then again, keep in mind back on this slide here that there may be some minor changes to the model NCD in terms of additional CPT codes or additional line edits, and there may be additional things added into the clinical evidence summary, particularly around facial reconstruction. But overall, the bulk of what is there is what is in there. So if you don't have any red flags with that, please do sign on, particularly if you are a healthcare provider. It's very, very, very important for the CMS folks to know that this is not just coming from the advocacy side, though of course as an advocate myself, I think I'm right. But it's always nice for them to hear it straight from the folks who are doing the medicine. So thank you so much for your interest in working on this issue. Really appreciate everyone's attention and patience with the difficulties that we had this morning. Again, if you have any questions, please email me at transgenderlawcenter.org. Take care. Bye-bye.